tonight's Queen Speaking of Health lecture on high blood pressure. How exciting is that, especially during American Heart Awareness Month? So you've come to the right place. Our lecture for this evening is called High Blood Pressure and the 2017 ACC AHA Guidelines. ACC stands for the American College of Cardiology, and of course, AHA stands for the American Heart Association. My name is Lisa Kia. I'm with the Queen's Health Systems, part of the Corporate Communications Department. On behalf of Queen's, I welcome you all this evening. It is my pleasure and privilege to introduce you to our main speaker this evening. He is Dr. Robert Hong. He is the cardiologist and chief of staff here at the Queen's Medical Center. I'd like to have him stand so we can give him a warm round of applause. And he'd rather sit. He graduated from Stanford University, where he got his degree in human biology. He received his medical degree from the University of California, San Francisco. He did his postgraduate medical training with an internship and residency in medicine at Beth Israel Hospital in Boston, Massachusetts. That was followed by postgraduate cardiology training at Los Angeles County University of Southern California Medical Center. He is a professor and also the program director for the Fellowship Training Program in Cardiovascular Diseases at the John A. Burns School of Medicine. He was awarded the Peter C.P. Char Excellence in Education Program Directors Award from the John A. Burns School of Medicine. He received a Kekauka Po'okela Award for Outstanding Physician from Queen's. And when I saw the list of his honors and awards, it would probably take me this entire hour to go through. So let's just say that we are very honored to have him speaking this evening, Dr. Robert Hong.
Thank you, Lisa. But, you know, being honest, I'm doing this in self-serving as well. I have so many patients that ask me questions. I just said, why don't you show up at the lecture? Because this has been one of the big issues that we're facing. And people say, why are we talking about 2017 guidelines for American Heart Association? I'm going to actually present this like we usually present academic presentation. Some people say that shouldn't be the case, that we should be kind of presenting at a lay level, but I disagree totally. I think that it's important, you know, for people to kind of understand the rationale and why we're doing things. These are the objectives, and a lot of slides are going to be busy. I don't expect you to read all the slides, and I'll try to point out the important aspects of the things. But these are the 5 points that, 4 points I wanted to cover, and 1 point I'll develop that. Well, basically, I'm pretty certain most of the people in the audience, except for a few doctors, didn't see this. But this was in November 2017. The American College of Cardiology and American Heart Association came out with the new guidelines on treatment of hypertension, and they had a whole bunch of other societies that contributed to that. Probably didn't see this article either, because this is in the Times of Mumbai. But this basically summarized what the article said, and it said, I mean, what the guideline said. It said high blood pressure is now 130/80, not 140/90. And if you didn't see it in the Times of Mumbai, you probably saw in the Star Advertiser that said half of the people in the United States now have high blood pressure or hypertension. And patients just kept on asking me and saying, what are we doing? What's going on? What are you planning to treat to, and how are we going through this? And it got more and more confusing. So I said, look, I'll just give a lecture. And it's confusing because we don't know the answers. And I'll be frank with you, there's a lot of things we have no clue about what's going on. And I'll try to give you some guidance through this. Hypertension is defined as high blood pressure. And at the end of the lecture, if you want to hear an esoteric lecture, then you ask me, why do they call it hypertension? But when you're born, your blood pressure is 60/30 to 75/45. And at 17, it's about 120/70. Previously, all the high blood pressure guidelines were directed at 140/90. And then we had the ACC/AHA guidelines. Now, what is blood pressure? Blood pressure is a critical thing. It's basically the pressure that takes through your arteries that perfuses all the parts of your body. Blood comes from the body back through the veins into the lungs, where it gets oxygenated and pumped back out into the body. This was kind of figured out by William Harvey in the 1600s. Now, when you have high blood pressure, you can imagine that it causes strain on the blood vessel walls, and that's what occurs. There's direct damage from high blood pressure when it gets super high, and you can have stress on the vessels to the brain, to the heart. But also what happens is you get atherosclerosis. Atherosclerosis means hardening of the arteries, and it basically is a response where the artery is trying to heal itself. When the blood pressure builds up in the vessel, it starts to rip the inside of the vessel, and that's where cholesterol deposits in, and then calcium deposits on the cholesterol, and that becomes why people get heart attacks. It's part of the reason why kidney disease occurs in patients with high blood pressure and why strokes occur in high blood pressure. Now, this is a purely academic slide. It shows you how blood pressure correlates with the pumping of the heart. I don't expect you to kind of know that, but basically the heart pumps and blood is ejected into the arterial circulation, causing, I don't know, this pointer doesn't work. Usually we have like this little arrow here, but oh, here, finally, where the blood pressure, the heart pumps and it squeezes out the blood. It goes through the aortic valve. The valve closes, which is this little bump here. There's a natural rebound in the vessels that get a secondary curve, and then it drops, and then it starts all over again when the heart squeezes and pumps it through. Now, we know that when you have elevated blood pressures, this is a logarithmic scale, which means that things double. It's not, otherwise you have curves that are shooting up like this and it's hard to understand. But basically, for every increase in blood pressure, systolic blood pressure, or the top number blood pressure greater than 110, you get a doubling in strokes. Stroke is when you basically close the blood vessel off or rip the blood vessel to the brain, and you don't have enough blood flow to the brain, and you get paralyzed or can't speak, or have problems with your sensation. Usually it's a motor phenomena. It's a movement phenomena in patients with high blood pressure. But for every 10 millimeters of mercury it increases through each age group, there seems to be about a doubling of the risk of stroke and a doubling of the risk of heart attacks. And so blood pressure is important, and it can cause damage. This is not a new idea. This is, if you take a look at the bottom of this slide, it says the Actuarial Society of America Blood Pressure Study in 1939. Since 1939, the insurers have realized that if you have elevations in systolic blood pressure, which is on this axis here, so it goes up like this, and elevations in diastolic blood pressure, which is on this axis here, which is not as clear. When I was told, don't do three-dimensional graphs, but I don't care. But if you have elevations in blood pressure, you get more problems. You get more heart attacks and stroke. That's clear. You get more renal failure and kidney damage that comes through. And it correlates probably better with the systolic blood pressure than the diastolic, and we'll kind of develop why. And that's been known since the 30s. In the 1950s, we started to, not we, but the World Health Organization and some other groups said, let's take a look at this across the world. And this is a 7-country study, including Japan, the United States, Northern Europe, Italy, Greece. And they all found that in their different things that when they had higher systolic blood pressures, they're worsening outcomes. And while this doesn't look like a logarithmic scale that's shooting up like that, that's what it kind of figured out. There are certain issues. So high blood pressure is an important risk factor in stroke, heart failure. If the blood pressure is too high, the heart can't pump. It goes back, blood backs up into the lungs and you can't breathe. That's what heart failure is. Kidney disease. High blood pressure is important in causing that rip in the vessels and secondary attempts at healing with atherosclerosis. And it contributes to cause of death in 2008 of about 350,000 Americans. This is not limited to America. This is from the World Health Organization. And the #1 cause of death worldwide is related to high blood pressure. You would imagine poor sanitation or something like that, or HIV, but it's high blood pressure. And high blood pressure is a big deal. And that's why you kind of come here to hear this lecture today. Now, while we recognize from the 30s and 40s and 50s that this is a problem, it was only into the 1970s that the main organization for research in the United States for healthcare, which is called the National Institutes of Health, assigned the subgroup, there are different subgroups that work on different things, or the National Heart, Lung, and Blood Institute to start to take a look at that. In 1973, when I graduated from Kalani, they figured out that we should probably get a guideline for the treatment of high blood pressure, identifying which of the population is at high risk and what's the right treatment regimen. Over the next 35, 40 years, there were additional 6 guidelines that came out. This wasn't limited to the United States. This is the WHO, World Health Organization, and a subgroup of predominantly European scientists called the International Society of Hypertension, who kind of followed the Joint National Commission, and they said high blood pressure is 140, top number, 90, bottom number. Although the committee recognized that this was purely arbitrary. As we said, the risk increased from 110 systolic and double with every 10 millimeters of mercury. And this stayed stagnant until about 2013. And then you can see this slide is not so you recognize the European College of Cardiology or the European Society of Hypertension, American College of Cardiology, and things like that. But what you see is in the past 5 years, there were dramatic changes. All of these societies started to come up with new guidelines. And the ACC guidelines came out in 2017 in November, saying 130/80. And this, almost as soon as it came out, was disagreed with by the American College of Physicians, which is the Internal Medicine Society, the American Academy of Family Practice, which is a family practice society, and we'll go into the ADA disagreed with it, the Nephrology Society disagreed with these guidelines, and what we're presenting today is kind of the rationale what happens. So up until 2014, everybody was kind of accepting this. This is the 8th Joint National Conference on Management of High Blood Pressure. And in 2014, we said, okay, if you're greater than 60 years old or equal to 60, which is a category I fit into now, your systolic blood pressure should be less than 150 and your diastolic less than 90. And if you're less than 60, it should be 140/90. And if you're in diabetics or you have kidney disease, it should be 140/90. And that was the guidelines that everybody kind of accepted until 2017 when the ACC, which is, I was governor of the American College of Cardiology for Hawaii. I went to all the meetings. I understand all this stuff. This is my professional society. And the American Heart Association, which we've been actively involved with, said, no, wrong. High blood pressure is 130/80. And that when people said, what the heck is going on? And, the other things that we should go through, that some things weren't really clear, and everybody should have lifestyle changes, and we're going to talk about that a little bit more. Everybody should have multiple blood pressure checks, and we should talk about that a little bit more. But the recommendations that came from this task force included starting medications if you had a risk for heart attack or stroke of 10% greater at 10 years, and you were to get a blood pressure of 130/80. And if you didn't have that risk, maybe 140/90 was kind of a cutoff. Now, how do you figure out the risk? Well, the risk is figured out starting from the Framingham Heart Study. In the 1940s and 1950s, people looked at a small town outside of Boston where they had a stable population, And they started to take a look, and the Framingham is a town. They figured out that there are certain risk factors that cause you to have strokes and coronary disease, including high cholesterol and smoking. This was confirmed in our own study, which is a seminal study, which is a Honolulu Heart Study, which some of you may have been participants in. But basically, if you have this calculator and you figure out your age, your gender, your race, your cholesterol, your HDL cholesterol, your systolic blood pressure, diastolic blood pressure, treatment, diabetes, and basically you get your phone. You put it, well, if you guys have phone, you have your access, you punch this in, and then this will use this fancy equation to calculate what's your 10-year risk of having heart attack and stroke, and if it's greater than 10%, then the American College of Cardiology said, well, then you should be on treatment. There's a general agreement. People say, well, that's kind of like too aggressive. But there's a general agreement if your blood pressure is really high, like 180 systolic or diastolic greater than 110, you should probably start drugs right away. And if you don't have high blood pressure, you should be checked annually. And this is what we published. It's a nice slide. This is a totally unintelligible slide, so I don't want you to take a look at it. But this shows on the left-hand side what the American College of Cardiology, ACC guidelines were, and they split it up into these four classes of definitions: normal, elevated, stage 1 hypertension, stage 2. This is the European Society of Hypertension, European Society of Cardiology, and you can see there's a lot more grades, a lot more stages. There's not a clear overlap. So when you have difference in opinions, that means we don't have a uniform understanding of what is going on. But one of the things that did become clear is if you apply these guidelines, now 46% of the United States, as opposed to 32% of the United States, were diagnosed to be hypertensive. And you added blood pressure medicines to 31 million Americans. And these are the things that came through. Now, this causes stir, so like anything else, when you have some controversy in your opinions, you get a lot of support by all of these other organizations, from the American College of Preventive Medicine and the American Society of Hypertension, representative. It doesn't mean that all of these societies voted for that. And as I said, almost as soon as it came out, these four groups said no. This is all wrong. And they published papers about why no. They published websites of how you can find out and no. And they said, why are you doing this? And basically, what happened is in the early 2000s, we started on with what's called the SPRINT trial. It was funded by the National Heart and Lung Blood Institute. And the concept was if you could lower blood pressure, we knew that if you lowered blood pressure 140 over 90, you had less stroke than if you had 150 over 100. But the whole idea was that how low should you end up going? And the study was convened, and they targeted systolic blood pressures less than 120. Diastolic blood pressures weren't mentioned, and they compared it with standard treatment at 140. And they published this in, this is the big journal for medicine. I shouldn't be biased. This is basically, the New England Journal of Medicine is basically the Boston Medical Journal or the Harvard Medical Journal. So we all kind of adopted that, and when I was at Beth Israel, it's, you have to, this goal is to be in the NEJM. But basically what happens is the NIH, through the National Heart and Lung Blood Institute, recruited a giant study of 14,000 patients, of which they could randomize only 9,000 patients, and they split it into two arms of intensive treatment and non-intensive treatment, and less intensive treatment. Now, first thing you have to realize is not the splits, but when we try to teach medicine, we have to take a look at what was included. Well, this is an older group of people. You have to be greater than 50. You have to have elevated blood pressure from 130 to 180. And you couldn't have strokes or diabetes beforehand. And you had to calculate a Framingham risk score of greater than 10%. And then they targeted and they split the groups, and they said the intensive treatment will go to 120 systolic, and the standard treatment would go to 140. Now, one of the weird things is when you start to take a look at studies, it's hard because you read the paper and you see the headlines, and that's the way the studies go. But really, that's why you have to work with your doctors, or your healthcare providers. This is the distribution that you see. There's a quarter of the people were 75 years of age or higher, and they didn't always have that high blood pressure. A third of them had blood pressures of 132 or less. A third of them had 132 to 145, and probably only a third of them were in the kind of high blood pressure range that we took care. But after that's said and done, all measurements, whether they took a look across all, whether you're black, older than 75, less than 75, intensive treatment seemed to be better. And this was a driver for the American College of Cardiology and the AHA to say we need to go lower. But everything comes at a cost. These are fancy medical terms you don't have to know about. But some people got low blood pressure. Some people passed out. Some people had injuries related to falls, and there was increased risk of all of these things, including kidney injury, in the patients treated aggressively. But after that's said and done, when you take a look at it, they had excellent results. They had excellent achievement of their goals. This is 120, this is 140, among the two groups. And then what happens is the graphs started to split. When you took a look at the outcomes in terms of strokes, heart attacks, hospitalization for heart failure, they started to split. And this was the driver, this one clinical trial was a driver for the ACC, AHA to say, nope, we got to go lower. This is true. This was presented in November 2015. This is the European Society of Cardiology conference in Rome in 2016. And you can see from the hands how many people agreed with this or not. They did the Roman thing with the up and down. And you can see the finger thumbs going all different ways. And that's what happens. And there was a big blowout about these things. And they said, one of the things that's a problem is that in the SPRINT trial, you did put a automatic blood pressure monitor on. And to avoid what we call white coat hypertension, people had to leave. Okay? And people say, that's not realistic. When do you go to your doctor and walk in, leave you, and check with the blood pressure monitor? And then went through that issue. And people went crazy. They said, well, that alone caused the blood pressure to be 10 to 20 millimeters lower than what you have. Then there was arguments about how they measured the blood pressure, and we're going to kind of go into these things. And people started to say, well, you're going to seriously harm people. And then there were other meta-analysis said, no, you're seriously going to help people. And so what happens is probably somewhere around this time, you went to your doctors, your healthcare provider, and you say, what am I supposed to do? And they said, I don't know. And the reason why is even before the SPRINT trial started, there was a trial in diabetics that looked at all the same parameters 10 years before. They did the same thing, it was called ACCORD, and they didn't find a difference between the aggressively treated people and the not aggressively treated people. And when you talk about this, diabetics may be 20 to 40% of people in Hawaii, And so now you're starting to kind of pan things up. That's why diabetics and people with strokes were excluded from the SPRINT trial. Accordingly, this was not only just one big trial, that was 2,000 patients, not the 9,000 patients that were in the SPRINT trial, but there were other sub-studies that seemed to show the similar thing, that more aggressive treatment was not necessarily associated with benefits in diabetics. And what happens is the ADA said no. The American College of Physicians said no. These guys are going too aggressive. You're going to have people passing out. You're going to have some kidney injury from too low blood pressure, and this is a problem. So, this is what I was actually having to talk to my patients, each one, and I'm going, no, don't worry about it. But my assessments kind of clear is that the evidence isn't complete. We don't know everything. But we have to change. We have to pay attention to what data we have to do. And some of the things that started to get to be an argument of 140 over 90 over 130 over 80. And realistically, that's not the point. You should be on lifestyle changes. People with high blood pressure should start to take a look at, everybody should be on some type of lifestyle changes. This is called a DASH diet appropriate to stop hypertension. And what you'd end up doing is you decrease sodium intake. You increase potassium intake. You don't take potassium pills, but you increase your fruit intake where there's natural potassium that's found within the cells. You decrease your weight. You exercise. The alcohol intake is recommended to be 1 drink for women, 2 drinks for men. You have to start to use a team-based care. I don't really have the time to kind of like check all my patients and go through this, and it's only recently that I had to kind of re-chase this all down. But you need a whole team of people to start to manage you. Another thing is that we pointed out, you just don't focus on blood pressure. Everybody's looking at blood pressure. If we're talking about one of the things that causing heart attack is cholesterol deposition into the vessel walls, or one of the things causing stroke, you try to correct the risk factor for it like that. So you stop smoking, you control your diabetes, you start exercising, you address other things like sleep apnea, and getting an appropriate treatment. And what this is, and what people have assumed, is that when you have high blood pressure, you take more medicine. And that's what I'm not saying. You get involved in your care and you start to do some lifestyle changes. Second thing, though, is these are the 4 questions. This is actually cut from the article about what were they looking for. Can you do home monitoring? What is the optimal target? Do we do different drug classes? And how many drugs do we end up using? This, I think, was the most important aspect that we found out with this. You should measure your blood pressure at home. Why? Because when you go to the office and you take in, like my patients say, 20 minutes to find a parking space, that's not reflective of what your blood pressure is at home. And so up to 1/3 of people have white coat hypertension. Now, it's not white coat hypertension, it's stress-induced hypertension. But if you treat that stress-induced hypertension, do you lower the blood pressure too much during the day when it's not around? And so this is what we've kind of taken a look at. We want our patients to be actively involved in measuring their own blood pressures. Now, to understand that, you have to actually understand what the concept is of how to measure your blood pressure. Basically, you put a cuff on, it compresses your arm and closes off the brachial artery. And when you lower it, initially when you're high, your heart is contracting, you'll have like little swishes through the cuff that you can hear with a stethoscope. That means the systolic blood pressure, the high number. The high number is when the blood is contracting. You assume that the pressure measurements inside the cuff represent the pressure measurements inside the artery, which is not always the case, and we'll talk about why. And then you lower it until you don't hear the turbulence, because you go into the diastolic blood pressure and the heart sounds disappear. Now, one of the most important things is you assume that the pressure in the cuff measures the pressure in your artery. Now, if you have a small cuff and a big arm, it doesn't work. Basically, you have to generate a lot of pressure in the cuff to occlude the big arm. And the opposite way occurs, there's equally a problem. You have a big cuff and a small arm. You're assuming that the pressure in the cuff is representing the pressure in the artery, and it's not the case. So you have to standardize cuffs. You have to do appropriate measurements. What are appropriate measurements? Well, this is the thing that actually I learned, and through this. You have to have a patient sit quietly for 5 minutes. Now, you go into your doctor's office, you're rushed in, I had this, especially with lawyers. I just say, sit it down for 5 minutes. I'll come and check your blood pressure. And the first thing that comes out is, your time is as valuable as my time, you know? And, you know, I've mixed that you're just messing around here doing something else for 5 minutes. I go, no, we're supposed to let you rest for 5 minutes. And realistically speaking, how often does that occur in your office? It should be, blood pressure should be timed to when you take your medications. If you take your medications, you know, 30 minutes or an hour before you take your blood pressure, it's going to be different than if you take your blood pressure, you know, 6 hours after you take your medications. The big problem, and this is actually not recognized and nobody talks about it this much, is, do we know that our home blood pressure cuffs work? Okay? Now, when we do this auscultation things with Korotkov sounds, we do it with a stethoscope. But really, the way automatic blood pressure cuffs work is that they lower blood pressure, and then someplace around here, you get oscillations of the pulse that comes through. You can see that the oscillatory systolic blood pressure is 145, and the earpiece blood pressure is 141. It doesn't seem a big deal, it's 4 millimeters. But that's not always the case. Each blood pressure company, pressure cuff company, has different algorithms for figuring out when this oscillation comes on and when it goes off. Okay? So you have to check where your equipment is accurate. The other thing that's important is that if your beat is irregular, if you have atrial fibrillation, your blood pressure is all over the place. You can't necessarily ask your blood pressure cuff to exactly measure things, because this assumes, when you use automatic blood pressure cuff, that you have a regular beat and there's going to be regular oscillations. Now, one thing, have I lost everybody here? Am I going too technical? Okay, tell me, because, you know, as we talk when we're giving it to our fellows or medical students, you know, once you get lost, you go down the woods and keep on going, all right? But okay, but let's kind of go through things. So people say, well, I don't want to know if, I just want to know, is my blood pressure cuff that I get reasonable? And you can go to different things, and you can go to, this is one of the big educational trusts that has looked at everybody's blood pressure cuff, and it's sponsored by the European Society of Hypertension, but also by a commercial interest. And they have all the blood pressure cuffs listed here, and they tell you how many times it's been validated. But the real problem they face is, if you get a manual blood pressure cuff and you listen to it with your stethoscope, you have like a lot of recommended things. This is the blood pressure cuff that was used in the SPRINT, the blood pressure machine that was used in the SPRINT trial, Omron 907. And you can see questionable, questionable, recommended, not recommended. And if you have end-stage renal disease, this doesn't work well at all. And is it how much your blood pressure cuff costs, your blood pressure machine, excuse me, not cuff, your blood pressure machine costs to figure out whether it's going to be accurate or not? No, this is from Amazon. You can see you can get Omron 710 for $24, and the one used in the study for $653, and Welch Allen stuff for $1,020, and the ones that are used in our office were, I think, $1,800. You know, and really they have all the problems that are faced with that, and the validation is not always that good. So outpatient blood pressure measurements, I think, are good, but what I would do recommend to people is that you go bring your cuff in, check with your doctor or your healthcare provider, and compare your cuff. And being honest, we don't even know how long each blood pressure measurement machine lasts effectively, because when does it lose calibration? When does the things, and the calibration is probably dependent upon the algorithm it uses to measure blood pressure. And blood pressure changes during the day. We know that, you know, it's higher in the morning, later in the afternoon. But regardless, if you want to get involved in your care, get involved in your care. Do the things that are necessary for lifestyle change to get your blood pressure lower. Get your blood pressure checked with your doctors. A lot of my physician friends not to like this, and get multiple blood pressure measurements. You know, basically, this is again from the ACC AHA things. It's too busy and stuff, but basically, you have to have somebody sit in a chair with their feet on the ground. You have to keep the blood pressure measurement at the level of the heart, so somewhere around here. You have to remove your clothing, what you put the blood pressure cuff on to measure, because if you have a big puffy down jacket, that pressure is not measuring. The thing, and actually, being honest, you know, our MAs are great, and we have wonderful, you know, healthcare assistants, but sometimes people are in a rush and they just put it on, and you come in, you go, did they take off your shirt? No. You know, these things are the thing. You got to get multiple measurements until you get consistency. You know, so we repeat our blood pressure measurements every 1 to 2 minutes until you get something within some range that you're acceptable. Usually, I think within 5 millimeters of mercury, systolic or diastolic. Okay? And then you write it down. And you measure it at different times of the day. So I tell my patients, get your blood pressure measured in the morning, unless they're just taking the blood pressure in the morning. I mean, medicines just before they take it. And get your blood pressure measured at night, and you take 5 measurements, 5 daily assessments that you've averaged when it's good. And you come in and bring it into me. And I actually, you know, a lot of doctors disagree with me, but I actually use that more as a gauge of whether blood pressure is being controlled than all our office measurements. Now, one of the things that happens is people say, well, you know, I want to get control, but my top number is going up and my bottom number is going down. Common sense, that's what happens when you get old. Okay? Why does blood pressure go up? It's because either the heart output increases, so if you have too much sodium, too much volume, you're going to stuff in a lot of fluid into a hose, or the hose gets stiffer. And whether you like it or not, you know, just like you can't read the same as you were when you're 20, you know, your blood vessels get stiffer, and invariably, as you look at different age groups, you get systolic hypertension of the elderly. Okay? The problem is that, as we show down, the bottom number tends to be dropping because you're getting a less compliant vessel. And the bottom number is the number that fills the coronary arteries after the heart squeezes. The heart squeezes, then it relaxes, and then it gets blood flow. So what do you imagine if you start to lower everything? You're probably going to get some problems with coronary perfusion. And there are arguments about this stuff, and we'll take a look. But let's just kind of give you this takeaway points. High blood pressure is important. Systolic blood pressure increases as you age, and controlling the top number is going to be difficult without dropping the bottom number. And controlling the top number and being overly aggressive can cause you to pass out and can cause more problems. But after that's said and done, even in our studies in the elderly and patients greater than 80 years of age, medications have been shown to be associated with improvement in outcomes. You should do lifestyle modifications as the first step. Don't go to your doctor and say, what medicine can I take? Oh, I'll double the medicine. Well, when you double the medicine, if you double the dose of medicine, you don't get double effect. You usually get maybe a 20%, 10% increase in effect. Pay attention to all those factors we could take, and pay attention to yourself. If you're passing out or you're getting dizzy, your kidney function is getting worse, you should be working with your doctor and say, maybe I'm too low, and you check your blood pressure. And people say, well, I know when my blood pressure is high, I get a headache, I get short of breath. Well, usually that's not the case. And I'll kind of go through an example stop smoking. Okay? And what we don't know is what's the best target for blood pressure control. Now, we had 50 years of clinical trials, back and forth, all of these things coming through. But none of these guys, standardize the blood pressure for home blood pressure monitoring. Most were done in the office. There wasn't a standard thing if you had to wait 5 minutes exactly and doctor had to leave and somebody had to check these things. So a lot of the data that we have may not be applicable to everyone. And the other thing that it comes through is, this is me at Tavaroa. You could pay to surf one of the big lefts, right? This is Shane Dorian at Tavaroa, okay? Now, every day the wave's different. Why do you think that your blood pressure is not different every day? And should we start targeting different blood pressures? Because, nobody would take, as a diabetic, would say, okay, I'm going to take a set amount of insulin, and whether I go eat ice cream or whether I'm following a strict diet. Your blood pressure likely changes depending on different conditions. And this is the big issue, and nobody in medicine knows whether we can titrate appropriately with results like we found from our SPRINT trial and our other clinical trial. We've had, hundreds of trials of high blood pressure. Okay, so I hope that we've got through this. Why is it? What is hypertension? High blood pressure. It's important because it causes end organ damage. What blood pressure level is considered hypertensive? I don't know. What can I do to help yourself? Lots. Okay? And so that kind of goes through the formal thing. Because, basically everybody's perception of danger is different. This is my son. This is in Moab, and this is somebody on a high line that's over this stuff. And this is a net that's 500 feet above the ground. And is that dangerous or not? I don't know. It's in People magazine. He's like leading a ceremony because these people later on jump off the stuff. Is this dangerous or not? That's him crossing we paid for a Stanford education for that guy. And that's him crossing Vernal Falls. But, you have to figure out, and for him, not dangerous. You have to figure out in your own mind what you're kind of willing to deal with and what you're kind of willing to accept. And really the most important thing is medicine is not like you go to the doctor and they tell you what to do and you do exactly the same. None of my patients listen to me. But if you really want to get in touch with this thing, you have to be involved in your care. You have to be involved in your diet. You have to be involved in your exercise. You have to be kind of paying attention to, if you're passing out, maybe my blood pressure is too low, and check your blood pressure cuff. Simple things like that. There are no simple answers. So I was told that I should leave 15 minutes for questions. But if anybody wants to ask me why it's called hypertension, I'll tell you. So first question, why is it called hypertension? Thank you. Okay. Because actually, I didn't know. I went to medical school and, I said, why is it called hypertension? It's like you stressed out or something like that. That's what's going on. And teaching is one of the most important things that we do. And when I went to fellowship, we're training cardiologists. So I said, how did they figure this out? And this is Stephen Hales. He was a reverend. He stuck a little tube in a mare's carotid artery, and they found that the blood went up 8 feet. After Harvey figured out that there was a circulation that goes through, and they could measure the blood pressure. But if you do the measurement of blood pressure like that in a human, just like the mare, they die. So the next big guy in hypertension was this guy, Richard Bright, and he looked at kidneys, and he found out that in people with kidney disease, because they couldn't get rid of salt, they started to retain fluid. You stuff fluid into a tube, the pressure goes up, and then they got heart failure, heart enlarged, small heart kidneys. But then nobody knew how to measure blood pressure. This is the thing. The Chinese from the writings of the Yellow Emperor, Huangdi talks about how you measure pulse quality, but nobody could measure blood pressure until these guys came along. They said, well, maybe we'll do this blood pressure measurement, and we put something on the radial artery, and we could get a little squeal like this. And really, the guy who developed motion picture photography, Etienne Jules Marais, landed up using this. This is his equipment. He actually did this. These are the flash photography showing a bird flying with the different things. But they were able to record blood pressure. And until the 1900s, this is how we measured blood pressure, by looking at how the pulse went through. This guy was the first guy to develop the sphygmomanometer. His name is Scipio Rivaracci. One thing that happened is his blood pressure measurement, what they would do is they put a blood pressure cuff up, and then they'd feel the pulse when the pulse came through. Unfortunately, this blood pressure band is too small to effectively transmit the blood pressure effectively to the brachial artery, so the measurements are all over the place. And it was a Russian guy, Nikolai Krolikov, who kind of figured out all of these things, and they started to listen to, you know, the heart, the whooshing sounds in your vessels in 1905. And the insurance companies in 1911, Northwestern Mutual Life said, sphygmomanometer is indispensable in life insurance evaluations. And then two of the greatest cardiologists of the 20th century, John Hay in England and Paul Dudley White, who was actually Eisenhower's cardiologist, said, the greatest danger to man with high blood pressure is because if you discover it, some fool will try to treat it. And it may be a compensatory mechanism, and we shouldn't mess with it. And so we had this thing called essential hypertension. How many times you go to your doctor, you go, essential hypertension? So in medical school, I go, what is essential about this? They said, oh, it's essential. I said, nah, this is not making sense. So I actually did historical research. And these are two guys that kind of motivated me to figure out what's going on. One is this guy who's an Indian, Frederick Akbar Mohamed, who lived in London in the late 1880s, 1890s. And he was, his grandfather was, I used to think this was Saki Din Mohammed, but it's right, Sheikh Din Mohammed. He was the first guy that kind of came in from Bengal, and he basically brought shampoo to Brighton. And he landed washing people, including George IV. He started the first Indian restaurant in London. He wrote the first Indian travel guide, and he married a white woman. So his grandson was still considered black. Yeah, I found this by the famous black physicians in England. But Frederick Mohammed used one of those sphygmographs, and he noted that the contour of it was like you had a pulse under high tension. So they called it hypertension. You know, that was the whole thing. It was mainly from this little machine that came in. But he was a poor guy, and he worked in infectious disease hospital, and I think he died of typhoid fever. That's his little thing, and it shows that, you know, died November 8, 1884. So how do we get essential hypertension? Well, it goes through this thing. This guy is a famous physiologist from the early 1900s, Otto Frank, and he put it in French, hypertonie essential, and he developed these things. But really, a lot of it came from the fact that if you're a giraffe, your blood pressure is high. Why? Because you need to get blood flow to the brain. And that was found by this guy, Harvey Cushing. And Harvey Cushing was one of the first neurosurgeons that came through. He actually was at the hospital next to where I trained. It's now Brigham and Women's, so it's Peter Brent Brigham. Went into he was at Yale, Hopkins. He figured out that every time they increased the pressure in the brain, the blood pressure had to increase to compensate for the pressure in the brain related to bleeding. And probably that's the basis of essential hypertension like that. Now, why would people say, why was it dangerous to treat it? Because up until 1957, these are the drugs that we had to treat high blood pressure. Rice water diet, cyanide, sympathectomy. The first diuretic that came out was in 1957. And believe it or not, all of these things, these treatments were so toxic that probably they cause as much harm as benefits, which actually is going to put us back to all of the trials that we've been talking about. But kidding aside, it was kind of funny because I went off on a tangent. I said, why is this important? Anybody recognize what's going on here? What are these two flags? This flag on the here doesn't exist anymore. Oh, you guys. This is related to this guy. You know who this guy is? Franklin Delano Roosevelt, who in 1940 had a blood pressure of 160/100. Yeah, he started to get heart failure. He was coughing, so he was treated by ENT physician from the Naval Hospital. And his blood pressure went up to 260/150 at the Yalta Convention conference. They sedated him, probably. This will not come out true because one of the big things that we could do is give, phenobarbital to our patients with hypertension. He had multiple strokes. When he died at age 63, and he looked a lot older than that, his blood pressure was 300/170. And he died of cerebral hemorrhages. And probably during this process, and this is argued whether he was sane enough or effective enough to deal with Stalin. And we split the world in two for 50 years. So high blood pressure has a lot of effects beyond, what we talk about today. So any questions? I'm supposed to ask real questions.
Okay, raise your hands if you have a question.
You don't have to answer questions too, because really the person you should ask is your healthcare provider. Don't, I will tell you, one of the things that ticks me off the most is when my patients come back from Las Vegas and they say, the doctor at Sunset Hospital told me. I say, okay, thank you. All right, you got a question?
I hope this is not offensive.
Sure.
I know what your age is.
Mm-hmm.
/Could you tell us what you think your typical blood pressure is?
It is variable because normally my blood pressure was 120/80. I just checked it before I came to this conference. It was 138/90. And that's the one thing that happens to all of us. Our blood pressure is not constant. You're preparing for a conference, you got to talk in front of people, your blood pressure probably higher. I run 3 times a week and surf twice a week.
Thank you.
I know there are symptoms of low blood pressure, but are there numbers associated with low blood pressure? So, what would be in the range of low blood pressure? I mean, we always talk about high blood pressure, but...
Yeah, how low can you get? Yeah. Until you pass out, probably not. No, but I mean, that's why I started off with this thing is when you're born, your blood pressure is 60/30. If you came into the ER with a blood pressure of 60/30, they'd be calling an emergency. But everything adopts at different points in time. And so basically, we know that probably the risk factors increase when your systolic gets greater than 110. Is 90 better than 100? Better than 105? We don't know, because the curves kind of flatten out at that level in terms of cardiovascular disease.
So my question is that, is there a number associated with low blood pressure? I mean, if you're looking for a number?
No, and that's the other thing that what I went through in the second part, when the World Health Organization said, this is a continuum. What is a normal height? When should you be treated for being too tall or being too... And I mean, this is a physiologic variation. Across everybody, there's different things. What is a normal skin color? These are the issues. But I think this is where you have to kind of work with your healthcare provider and say, what am I trying to treat? Okay, I have a patient with heart failure, weak heart. We may target a totally different blood pressure than somebody who's 22 who may have isolated systolic hypertension of the young. You know, we have different targets because there are different outcomes. If you have patients with diabetes, you may be looking for a different target than I would like in other patients, you know. And so this is the whole thing is, that's why you cannot go to a lecture and then walk out of the room and then go talk to your doctor and say, Dr. Hong said 130/80, and that's the number I should be at. No. Everybody has different comorbidities. Everybody has different responses. Some people faint. When they get low blood pressure, they may faint more. You know, one of my friends actually did this thing that got published in New England Journal of Medicine with 20 patients. They went to the Hebrew Rehabilitation Hospital of the Elderly, and they found that 25% of their patients, after they ate, got low blood pressure. Why? Because the gut expands. Now, they might not have low blood pressure if they didn't take their blood pressure medicine just before they ate. You know, there are a lot of factors, and this is where you shouldn't just use hard pan rules. You have to work together as a team. That's the one thing I'm trying to take away. You got to be responsible for your own health. It's not the doctor's responsibility.
Okay, thank you. I have a question on
Hi, doctor. I would like to know one thing. The consumption of sodium increases your blood pressure.
Why?
But how about coffee and sugar? Those are my weaknesses.
Yeah, so everything increases your blood pressure. No, I mean, because effects of coffee are usually transient, but sugar, if it leads to obesity, basically you'd need higher blood pressure to feed your fat cells. It's not completely true, you know, but that's a generalized thing. That's why weight reduction is one of the important ways that we get blood pressure to get to ideal body weight. And if you're eating sugar and you get diabetic and your blood pressure is reasonably controlled, that's not good. You know, so living a healthy lifestyle is reasonable. But, you know, we just went through this rounds yesterday. Nobody lives forever. So choose how you want to live. I mean, that's a base thing. People came to tell me all the time, you saved my life. I said, nope. You know, we extend your life, and it's up to you to have the best out of what you have with your life.
Okay,
Thank you, doctor. I'll change my lifestyle.
Okay, I think this is the last question, yeah?
This is a great talk. I've battled this for years and years and years. I'm very active, did the Great Aloha Run, extremely active. I take meds, and it doesn't go down. What I found was interesting is your things about the cuffs. You go to the doctor's office, they have one cuff fits all. Yeah, it fits large men's arms, it fits skinny little women's arms. So that cuff size in a doctor's office, does one size fit all?
No, we actually have different cuffs. But, you know, if you want to help things out, help buy your doctor a cuff. No, I mean, you don't take a look at this, but primary care physicians are being capitated by and large. They get paid no matter how many patients they see. So, you know, if you want to have a good relationship with your doctor, don't necessarily always bring lunch. You know, bring things that are useful to you.
Okay, I'm sorry. We have one last question with the man here.
My question was, you know, they have that, to figure out your weight, the BMI, the body mass index. Do you use that in terms of figuring out, you know, your age and what your weight should be at?
We use it all the time. If you have electronic medical record, it's always under the vital signs of your body mass index. The problem, everybody in America is getting obese. I mean, that is basically true. And all of you guys who travel, if you go to Japan, you know, you wonder why they thought sumo wrestlers were unusual, you know, because there's so many skinny little people running around. And even that is changing in Japan. You know, Japan was in Chiba Prefecture, Chiba Prefecture, they found the people that lived in the mountains had lower blood pressure than people who lived near the ocean. Why? Because of salt. Okay. You can ask any questions, but really, I would encourage you to ask your healthcare provider, and don't ask me, because I don't want to hear about Sunrise Hospital again.
Our next lecture for March 28th. March is, it's called National Colorectal Cancer Awareness Month. So we're going to be talking about plantar fasciitis. No, we're going to be talking about preventing colon cancer. Don't wait until it's too late. Colon cancer is the second leading cause of cancer deaths in the United States. And we're going to have Dr. Christy Lopez, who is a gastroenterologist at the Queens Medical Center. She's going to be talking about colon cancer, the warning signs, the risk factors, detecting and removing polyps, also ways to lower your risk. That is, again, Wednesday, March 28th, 6 to 7 p.m. right here at the Queens Conference Center. If you want to sign up, you can call the Queens referral line at 691-7117, or go to our Queens website, queens.org, and click Attend a Class. That's going to do it for this evening. I want to thank all of you for coming to Speaking of Health. Have a great evening. Drive safe. Take care.